Running quite late now. Yeah, what this is. Yeah.
Just have to run for a minute. I'll catch you on the
I saw
other
Dr.
You register? Or what?
Could you run more minute?
Yeah. So good friend.
Can people in the back hear us?
Yes.
So good afternoon, everyone, and delightful to see all of you here for the part 2 of the non-communicable diseases session. Yesterday we had part 1 where the panel covered the cancers and the growing oncologic problems in India. Today we are going to cover the rest of the non-communicable diseases which are becoming very prevalent, very important, and healthcare burden to the US. So, if you think about non-communicable diseases, it is the part and parcel of modernization, westernization that has come. The same thing that has increased our GDP, the same thing that has increased our connectivity, are the flip side of it. It has brought in all the risk factors that come with it that the developed world has seen, and now India is grappling with this problem. So in the next 45 minutes, we are going to deal with some of these non-communicable diseases and things that the panel is doing in various ways. I'm not going to read out one of these numbers, but essentially 2/3 of the deaths in India are happening in young population between ages 30 and 60 are preventable because of non-communicable diseases. There are various surveys that are done. It was showing rising prevalence of mental health diseases, diabetes, hypertension, and all the other underlying factors that contribute to these problems. The days when tuberculosis, malaria, diarrhea used to be the number 1 causes have changed completely. And now, if you look at the newspapers, they are number 5 and number 6 causes of deaths in India. So we are dealing with a silent epidemic, and now I don't think it's silent. A lot of people know about it, but still in rural and urban setting, I think the education may have a role to play here. It's on to Uttara. Okay, so I could introduce myself. I'm Chirag. I'm the division director of nephrology. I'm at Johns Hopkins, and I also do. I'm a physician scientist. So I do immunology and translational work in kidney and cardiovascular disease. And more recently, we do work in data to develop this model with electronic health systems.
Thank you, Chirag. My name is Uttara Kumar. I'm with the Center for Communication Programs at the Johns Hopkins University Bloomberg School of Public Health. And as Chirag was saying, my interest in this whole area is from the angle of social and behavioral challenges, because as you see, health systems can get immensely burdened And we keep talking about hospitals being overburdened, nurses being overburdened, medications becoming prevalent. But are we ever thinking of the other end of things where we could, much of this could be preventable and reduce the burden on the health system? So if I can ask a question, how many people here in this group have someone in their immediate family or yourselves who's experienced a premature cardiac situation? About half, let's say. How many people in this room know someone in your immediate family or yourselves have died? Okay. How many people know a young person in your immediate circles, maybe more, who's struggling with mental health challenges of some kind, with anxiety, depression, or even something more severe? Again, more than half. So this is a quick survey. This affects all of us in some ways. And so today we're going to hear from the panel looking at some of the root causes, the rising prevalence for NCDs and looking at common underlying behavioral drivers, things like obesity, high blood pressure, changing lifestyle factors for young people and adults. And the panelists will share some insights on addressing why this growing burden like NCDs and cardiovascular, kidney disease, diabetes, mental health, etc., is growing in India and keeps growing. And we'll have a little bit of discussion around recommendations and solutions. So each of the panelists will present about 5 to 6 minutes on their area of expertise. And then we have the moderators have a question for them. And then we will, if time allowing, open it up to some questions from you. So while they come from very varied backgrounds, you'll find there's some common themes as well. So I'd like to introduce our first panelist, who's Dr. Thiagarajan. He is the Chief Scientist and the Director and Founder of Sapien Labs. I'm not going to go into anybody's bios, they're long, and I think you'll be able to read them yourselves in the program. So let me invite Tara to start with her presentation.
Thank you for the invitation to be here. So a very quick introduction to what we do at Sapien Labs. We run the Global Mind Project, which is the largest and most comprehensive survey of the internet-enabled population, and that's an important qualifier, where we capture data of a very wide breadth of mental health factors, as well as a whole lot of aspects of life context and lifestyle. We also run centers for human brain and mind. Our first centers are in India and in Tanzania and East Africa, where we look on the ground in both online and offline populations at the relationship between various environmental lifestyle factors, what it's doing to brain physiology, and what that means for mental health. So what we are most interested in tracking is what we call mind health, which we define basically as the ability to navigate life's challenges to function productively. So mind health, essentially, we have an aggregate metric that integrates across the 47 organs that span these various aspects of the mental condition. And this metric, which I'm going to show you the data on, is called the mind health quotient. And what you can see, it's a negative positive scale. At one end of the scale are all of our folks who are struggling with serious mental health symptoms. At the other end of the scale are people who are thriving. And if you look at it in relation to reported productive days, this metric scales roughly linearly with your ability to be productive in life. So it's essentially a functional readout of our mind health. So before I go into what the mind health or mental state of the world looks like, I want to tell you a little bit of history. So back in the 2000s, mostly sociologists and economists started measuring well-being. And these are mainly questions around happiness and life satisfaction and well-being and so on. And what they found was young people in this 18 to 21 range always reported the highest scores here. It dipped in middle age and then it went up 10 in older age. And this became known as the U-shaped curve of happiness. That's what it looks like now. Okay, so when you go and look at mind health itself, what we see is that every younger generation every younger age group has lower and lower scores on this mind scale. Now, the way the scale was constructed is such that the 100 line is where a normal population should be. So you can think of it a little bit like the scale structure, like, what an IQ scores with an average of 100. So when you look at mind health of older adults across the globe, this is 85 plus. And you can see most countries are in this range over here. And if you look at that histogram in the corner, it sort of centers around this value of 100. Now you go to younger adults, age 18 to 34, and you can see that every single country has slipped down the scale. And if you look at the distribution, it's actually shifted profoundly to the left. And what you can also see is a lot of the more developed countries are also struggling more than some countries like sub-Saharan Africa. Do a deep dive into India, and this is a different scale entirely, but same concept. You can see that across all states, and again, internet-enabled population, that the young people are struggling. So what is driving this phenomenon? Why does this happen in the last 20 years, 15 to 20 years is when most of the shift seems to have occurred. Okay, so the emerging big buckets are the chemical environment, and the other aspect is the techno-cultural environment. So I'll tell you a little of where the data is pointing now. And of course, there's many other factors to the chemical environment that I put here. But if you look at ultra-processed food, hundreds of chemicals have entered the food system in the last decade. Many are neurotoxic. What we see in an aggregate is that it's associated very much with, creating challenges to the ability to control and regulate thoughts and emotions. Plastics and plasticizers still emerging. We're breathing them in, we're eating it. Lots of microplastics emerging in the brain now. It seems to have a diffuse effect, but this is an emerging story. Smartphones, especially when you give them to children under the age of 13, they end up very, very likely as adults have suicidal thoughts, feel detached from reality, and have greater aggression towards others. Sedentary lives have the more physical effects, energy, sleep, pain, and then disintegrating social bonds, which create challenges for, you have unwanted obsessive thoughts, social challenges, and so on. I'll give you an example of this in India. This is an interesting phenomenon here. So the red line that you see, if you can see the scale, it's the age group. So on the left is the younger age group. And you can see that with each younger age group, reports being less close to their families. And then than the older age groups. And this is true for English speakers on the internet, but not for Hindi speakers. So there's a cultural element in this. And maybe that would be fine, except that when you look at what that does to mind, what you see is the better your MHP scores. Now, income, of course, has a positive effect. But on the other hand, if you have and you have income of greater than 10 lakhs a year, you're going to, on average, people are doing as those who make less than 1 lakh a year and have very close family. So basically, the trading off love for money doesn't work out for your mind. Okay. So where to from here? So I just want to give you one very important statistic, which is that the number of therapists and the number of psychiatrists per capita have no correlation whatsoever to the mental outcomes of countries. We see in the United States that over $1 trillion has been spent on mental health in this country, with the result that mental health is got several times worse, and is doing worse than many countries that don't spend much money. So this is not just, so we really need to change our paradigm completely, where we start focusing more on understanding root causes and tackling root causes and evaluating and integrating and preventative solutions for root causes. So this is a crisis, equally a crisis of economy and of development as it is of the healthcare crisis. And we are seeing now, for instance, this data and work has now found its way to the Economic Survey of India. You have heard this morning, the recently released UN Human Development Report. And this assessment now forms part of the presently ongoing National Mental Health Survey of India. So I think a lot of work to be done on many, many different dimensions. And if you want to learn more, you can scale on this page for another meeting. Thank you.
Thank you. Next speaker is my dear friend Prabir Roy-Chaudhury. You want to sit? Or you
No, I'll just speak without slides.
okay.
Should I just take?
Prabir is the president of American Society of Nephrology, which is a kidney association with over 21,000 members.
Thank you, Chirag. I'll just, if you could just put my first slide on, and then I'll just speak to that backdrop. So there's no way I can beat your statement that you made, yeah. So, so I'm a nephrologist, very similar to Dr. Parikh, and what I'm really going to try and do over the next 6 or 7 minutes is to tell you about the challenge that we currently face with regard to kidney disease, but also, I think, particularly in the context of India, to share with you some incredible opportunities. So I'm going to start very similar to the way you did, Uttara. How many of you know somebody who has kidney disease, is on dialysis, or has had a transplant? Okay. So actually, for a condition that until recently was really quite rare, I mean, there are a fair number of people. So I'm going to start off by saying that we're currently across the world in the middle of an epidemic of chronic kidney disease. The definition of chronic kidney disease basically is when your kidney function, which let's say normally is at a level of 100, goes down to 60 or less, and or you start leaking protein in the urine. There are 4 things about chronic kidney disease that I want to share with you. Number 1, it's common. Number 2, it's deadly. Number 3, it's costly. And number 4, the care of chronic disease across the globe is extremely inequitable. Very briefly on each of them, all across the world, and this includes India, the overall prevalence of some form of chronic kidney disease is around 12 to 14%. There is some variation in India, the south and the west, interestingly, the same areas that you had focused on, actually have a somewhat higher incidence of chronic kidney disease in India. The other thing about chronic kidney disease in India that I think is very important that's very important is that there is a relatively high incidence, about 8%, of something called chronic kidney disease of unknown etiology. It doesn't occur just in India. It was initially described in the state of Andhra Pradesh. Now it's been identified all over India, but it also occurs in Sri Lanka and in other agricultural communities across the world. It's thought to be associated, we don't know the etiology, it's thought to be associated with heat and with dehydration, possibly with pesticides, possibly with things like silica. And I think this is an area where there's a lot of investigation going on. But coming back to the main thing about kidney disease being common, what that 13% means is that globally there are 850 million people with kidney disease. About 150 million of those people are in India. 37 million of those people are in the United States, right? So it's an extremely common condition. One of the biggest problems with kidney disease is that as your kidney function decreases, so too does your chance of cardiovascular disease increase. And so the message here is that in addition to being very common, it also causes a lot of problems, right? That's the bit about kidney disease being deadly. And it causes problems mainly because of the cardiovascular issues that people with kidney disease have. So if you have a significant amount of kidney degree, you could have 20 times the chances of somebody without kidney failure of actually developing cardiovascular disease and other complications. And so heart and kidney in many ways go together, and that goes to this larger picture of chronic kidney metabolic, of cardiovascular, I beg your pardon, of cardiovascular kidney metabolic disease all coming together, right? So what I've said till now is it's common, it causes a lot of problems. And one thing that I didn't say, because I wanted to go away from my slides, is that one of the reasons that it's increasing is that most causes of kidney disease are as a result of diabetes and hypertension and some forms of inflammation. And clearly, we know that obesity and diabetes and hypertension, we'll hear more about it, I think, from Dr. Appel, are increasing around the globe. I want to go now from this area of kidney disease causing a lot of problems and a lot of deaths to the issues of cost and inequity. So in this country, being on dialysis for 1 year, and by this country, I mean the US, it costs you $89,000, and the state Medicare takes care of it. And remember, that's in comparison to a per capita income in the US, let's say of about $60,000, $65,000 a year. When your kidneys fail completely, we say you have end-stage kidney disease. You can survive at this point in time only with dialysis or a transplant. Dialysis is extremely expensive, as is a transplant, or be it cheaper. Let's go to India. What is the cost of a year of dialysis in India? So in India, a single session of dialysis costs between 2,000 and 4,000 rupees. Some places it's subsidized, so you can actually get it for perhaps as little as 1,500. But if you take an average cost of 3,000 rupees per dialysis and you do the mathematics, it comes out to 4.8 lakhs a year. The average per capita income of India is 1.72 lakhs. There are 3 states, all small states, Sikkim, Goa, and Delhi, where the per capita income over a year is more than what dialysis costs over a year. And one of the things that is really important to remember for India and end-stage kidney disease is that even though the government has come in with Ayushman Bharath, as you've heard about, and even though there is a national dialysis program, over 50% of the cost of long-term dialysis is still borne by the individual patient out of pocket. And what that means is that kidney disease, even if you get dialysis, can often be a death sentence, if not for the patient, for the family resources, right? We know that all chronic diseases put people into poverty. Kidney disease, unfortunately, does it better than any other chronic disease. And again, if you look at dialysis globally or worldwide, most of the people who get dialysis get it. The data are actually quite interesting. About 60% of the people who get dialysis on this planet actually belong to, come from countries that only contribute about 12% of the population. And if you look at low and lower middle income countries, then you have a number that the number of people on dialysis is about 30 times less than in upper income countries. So all of this sounds bad. But I am here also to tell you that this is a time of incredible change for the kidney world. What are the solutions? The solutions are not rocket science. They're actually quite similar to solutions for other chronic kidney diseases. They start off all the way from education and awareness, and then they go to early diagnosis and treatment. They clearly include, even before early diagnosis and treatment, losing weight, doing exercise, having the right diet. But then if you're able to diagnose kidney disease early through very simple tests, a blood test and a urine test, we now, for the first time in my 30 years as a nephrologist, have new therapies that can be used. So throughout my career as a kidney doctor till now, we had one group of drugs to be used for kidney failure. We now have 4 groups of drugs. I see, that's what you were telling the other person. Time's up. We couldn't read it then. I was wondering why you were putting the white sheet. Okay, I'll finish up very quickly. We now have 4 different types of new therapies for kidney diseases. And the wonderful thing, and I do say the wonderful thing, is that a lot of these drugs are becoming generic. So there is this huge opportunity in India to use these new therapies. Remember, I spoke to you about different costing, 4.8 lakhs for dialysis, 1.72 lakhs per capita income. Well, you can get a year's treatment with a drug called dapagliflozin for 1,825 rupees. Isn't that an amazing? I know I sound like I'm coming from a pharmaceutical company, but what I want to say is I want to make a plea to all of you really that we have this opportunity in India and in the US that if we can diagnose early, we actually have treatments that can reduce the progression of chronic kidney disease and that can prevent people from getting onto dialysis. And that's why I'm going to end with the title of that slide, which says, yes, we can. We're harkening back to the Obama days, cure kidney disease, but we have to do it together. One of the things, it's the last thing I'm going to say, one of the things that was very important for me in this meeting was how many discussions were had in areas outside of medicine that were very impactful with regard to medicine. So if I had to try and cure kidney disease in addition to the diagnosis and the treatment, I would say public policy is important. I would say getting an integrated workforce is important. I would say looking after the environment so that people don't get chronic kidney disease of unknown origin is important. I would say investment in kidney disease is important. I would say microfinance and innovative insurance systems are important. So all the things, I would say that data is important. So all the things we've heard about in this meeting can actually be applied into kidney disease. And then finally, what's the most important thing that we need to cure kidney disease? A question to the audience. What's that? Prevention is what? You also need champions, right? I want all of you to be champions for kidney disease, right? You need people. That's what I mean.
Thank you. Thank you, Prabir, for that inspiring talk. And next is Dr. Larry Appel, who's again a dear friend, advisor, colleague, and a mentor. And he's very well known for his pioneering and landmark clinical trials in diet and hypertension. Received Lifetime Achievement Award from American Heart Association. Larry, for yours.
Can you hear me?
Yes.
Thank you very much. I think my time's up. Since it's very popular to ask the audience a question, I wasn't planning on doing this, but I might as well, since the last two speakers did. So, how many of you either have high blood pressure, family member who has or have high blood pressure? It'd be 100%, quite frankly.
They're not listening.
Oh, okay. So, going to
That was nice. You said.
Okay. Oh, yeah. Okay, great. Okay. So, I'm going to talk about hypertension control in India. I'm going to allude to a hypertension control initiative that I think is very important. And to echo what Prabir just said, this requires everybody. Multi-partner approach to preventing and controlling hypertension in India. And believe it or not, also I'm probably 1% in this audience who has not been to India. So I'll be very careful about saying what goes on in India because I haven't been there. But I work with a team of people, many of whom live in India or work. So this should not be new to you, given what we've heard from the last two speakers. So 1.4 billion people have hypertension, and of those 200 million live in India. So what you probably don't know, hypertension is the leading cause of preventable death worldwide. For immediate costs, okay? Remarkably, little money is spent in terms of research on that. And that's why the results to save lives, which is some initiative that is focusing on this. And what is really interesting is that hypertension can be controlled, prevented and controlled. But this graph really shows you where the problem is. So there are close to 200 million people who have hypertension. Only 70 million are aware, only 57 million are treated, and only 27 million are controlled. That's dismal control rate. That's less than 14%. Average is around 40%. In high performing medical systems, integrated medical systems, like Kaiser Permanente, it can be 80%. Okay. So the good news is there are opportunities for change. Bad news is that I think it's going to require large system change in order to do that. So the India Hypertension Control Mission is a multi-partner approach. It's actually part of a national NCD program in India. There are many partners, the Ministry of Health, the India Medical Research Council, WHO. I underline RTSL, that's Resolve to Save Lives, and that's what how I am involved with this initiative, and then state governments. And what is really important is that this WHO actually has a package called the Parks Technical Package, and they have 5 sort of key elements to that. And one is the standard treatment protocol, a very simplified treatment protocol. Part of the problem with medical care for hypertension is that a lot has been too individualized, and it makes it really difficult and expensive to implement. Second, and I think this is really one of the Achilles heels in India, is the uninterrupted supply of medications and also validated blood pressure monitors. It's striking to me that India actually manufactures medicines, ships them abroad, but doesn't really, I think, generate enough medicine at the same time for its own population. And there are generic drugs like amlodipine that are actually, cost cents. But there's an inadequate supply. Team-based care, it's not just physicians, it's others who could be involved. Patient-centered care, bringing care close to home as opposed to larger facilities that are distant from where people live. And then information systems. Data is really important. So I'm just going to describe 2 projects that we can give you a sense. The first actually comes close to my home, which is dietary approaches to control hypertension. And one of the things I'm very interested in is sodium reduction. But sodium reduction is actually a challenging behavior given the food supplies. And so very recently, there's been a lot of interest in potassium-enriched salt substitutes, and these lower blood pressure, and in a major trial in China, reducing mortality by around 15%, and also reduce stroke by the same amount. Of course, with kidney disease, there's concern about high potassium, and so there could be some deaths associated with that, but the net effect is actually a benefit. And then path shifting. This gets to system changes. And so one of the things that we are interested in is the effects of multi-month refills, as well as shifting the task among a group of healthcare professionals, not just physicians. So this issue about multi-month refills is really fascinating to me. When I learned about hypertension control in India, I learned something that I thought couldn't be right, which is that patients had to come often once a month to get a refill, and often they would not get the medication. So if you have hypertension and it's controlled, I mean, every month you would have to go to get a refill. Now, interestingly, that during COVID, they loosened that general approach, and they would make 3 months supplies available. But if you actually go to 3-month supplies and you use, tax shifting, you can dramatically increase the coverage of hypertension. Those are the kind of projects that we do and resolve in terms of like pointing in the directions of things that could be beneficial. And these are pretty much system changes. So I think that's the end of my talk. And thank you for your attention.
Thank you so much, Dr. Appel. Our next speaker is Dr. Dinesh Nair from the World Bank. He's going to talk about a study in India in particular, but from his broader experience in the World Bank working in the States.
Hi. I hope you can hear me. And great that I'm coming after such an impressive array of speakers. And rightly after Larry's talk, which is very much related, which mine follows very well. And we basically look to targeting it the next 5 minutes to a conversation around one state in India, Tamil Nadu. Tamil Nadu is a better performing state compared to the 34 odd states that India has. But again, with growth, with development, NCDs account for almost 69% of the deaths. Almost 40% of the adult population are overweight. And one of the interesting facts about Tamil Nadu is, despite everything, there's a lot of belief in the public sector. And because as part of the World Bank Group, we work with the public sector, it's almost 63% use the public sector compared to many parts of India where you'll see the private sector is very much part of that. The bank was working with the government of Tamil Nadu over the last decade, but for the last 5 years, we've been actively engaged in a support program that focuses on strengthening management of non-communicable diseases. Tamil Nadu has an NCD care strategy, which basically focuses on people-centered delivery. And I know many of you know about people-centered. It's basically about trying to get care focused around the citizen or the individual. It's about working across the system around community and family empowerment, as well as a system whereby you basically prioritize evidence-based interventions and actually scale it up and implement it. Tamil Nadu around 2020 started this very interesting program called, in Tamil, it is called the Makkalai Thedi Maruthuram, which is basically doorstep care delivery. And basically some of the few elements that they included within that is NCD drug delivery, palliative care services, the physiotherapy sessions for stroke victims and others, as well as providing referrals and dialysis support. As Larry mentioned, it is an integrated approach, which basically requires a multidimensional team approach that is there, starting with the women health volunteer that goes house to house, providing drugs, but also most importantly, behavior change communication, supported by village health nurses, the mid-level health provider, a palliative care nurse, and all of this connected to the primary care centers, and therefore thereafter to the district and the other higher levels of care. Some of the, as clearly, which is one of the key moot questions for this talk, is about the risk factors. And across some of these studies, and I'll refer to some of them down the road, is while we've seen a decrease in tobacco use as well as alcohol use, lifestyle changes, especially beginning to show with increasing overweight, obesity, inadequate physical activity, and still diets continue to be a major issue where people are having high carbohydrate driven diets. We worked with the Hopkins Institute to looking at looking at non-communicable diseases, had an explorative study, looking at what are the barriers to seeking screening and care. And they cut across a range of areas, starting from structural, which is about access to care, institutional, about non-availability of screening services, social and community level, for example, in mental health, which we heard earlier in this session, about stigma, about household and social networks, the support that is required from the households, but also about lack of awareness and the fear of finding something fatal. Let me come down to the chase to just show you some trends that we saw in the information. We did 2 rounds of the STEP survey, which is the gold standard for actually looking at community-based prevalence and how the outcomes are. We had a baseline that was conducted in 2019, led by the National Institute of Epidemiology, which is a Chennai-based institute. And then while the program was closing in 2023-24, looking at various, while we have data for the behavioral factors, but we had more importantly data about hypertension and diabetes. And actually this overlapped with the MTM program. So it really gives you a sense of the direction that is there. You can see again, as earlier speakers have said, there is a vast gap between people who know that they have the disease to people who are put on treatment and then who are actually under control. So actually, if you look at it in hypertension, we saw in these 4 years an increase from 7% of those who knew that they were hypertensive and had it under control, increased by about 8 percentage points. And similarly, in diabetes, it was from 10% to about 16%, which is fairly good. Like if you look at some of the other best performing states, it is still around 19% that is there. So what are some of the big lessons that I take away from this? And how do you really, because if I want to leave one message with you, is care of NCDs is not just hospitals and care, it's an integrated care that is required. It starts from the house, it starts from the basic health centers, because people need continuous care. We cannot depend upon the old way of just going to a hospital, getting your fix and coming back. It's about how you make those small changes in lifestyles. So clearly primary care is the first point of contact. And that is where everything should start. And unfortunately, across countries, we have seen primary care is the weakest because it's the most unattractive. And therefore it always is a challenge to get it to have the right people and to actually man that. Again, social behavior change is a very important part. And having clearly addressing this with layered solutions is something that is very key. A third key point, which is again, as Larry was mentioning in a side conversation, it's about political commitment. It's about robust supply chains, because when you need care, you need to make sure that the drugs are there. If people are coming once in 1 month, you need to make sure. And this is where I saw Tamil Nadu really put its money where it meant to really show that they actually increased their drug supply budgets. Multidisciplinary teams, vertical integration between primary, secondary, and tertiary care. Information systems, again, is very integral because it's like so disjointed, even with all these IT packages. We, after 4 years, succeeded in doing it in one district out of the almost how many districts are there in Tamil Nadu, just as a model, but to get it rolled up is really linking people from the community right to the hospital level is going to be a very tricky thing. And India has the right background for it, as we heard, but we need to continue to work around it. And most importantly, quality of care, which needs to go across all levels. I'll stop there, but hope to have an engaged discussion. Thank you.
Thank you so much to all the speakers. I know that we are all running a little bit behind time, but we've kept amazing time at this panel. We're at, everyone kept to their required time. So we'll open it up to a couple of questions if there will be an opportunity, and we can maybe pass around a microphone to those who are who want to ask a question.
I have one request from the audience. I've set out a poll in the app. So if you guys can open it and answer the poll, maybe I can share the results in next 5 minutes.
Thank you.
Thank you. You hear me?
Yes.
Yeah, thank you. My name is Sundar Ramaswamy, and I'm a professional economist, and I learned a lot from this panel. I have very little expertise in what you all have spoken about. But the question I want to ask, given Prime Minister Modi's also simultaneous emphasis on the Ministry of Ayush about what's the scope for the traditional systems of medicines for addressing many of these issues that your panel raised?
Thank you, Sudesh. And a couple more questions, because in case there are some similarities, we might be able to cluster them. Any other questions? Hand over there.
I have a similar question. For older patient who has multiple comorbidities, like blood pressure, diabetes, heart disease, kidney disease, how to deal with them in India? Because basically it's a big issue in the US about the general population, and I don't think we have a very good solution for that.
Thank you.
Hi, thank you. I had two questions or kind of comments. One was about, we talked about how there's increasing obesity in India, and that's obviously related to all these non-communicable diseases we talked about. But there's also a number of people in India who are not obese who still have these non-communicable diseases. And I just wanted to see if anyone could comment on what the approaches are with that. And kind of relatedly to that is that a lot of times when we're trying to think of national guidelines in India, there's so much regional variation in terms of diet and physical activity and all of that. So how do you foresee being able to have national guidelines that can help everyone in India?
Thank you. Maybe we'll take the three.
I can take the last one because it's funny, people will remember it. So Indians say they are thin, and so there is an acronym when we were in medical school, we call it MOTA. It is metabolically obese thin adults. So what has happened now in India, if your BMI is 25, you are high. So the new guideline for Indians coming out of the Masala study is 23. So one of the take-home messages in India, if you say somebody is MOTA, his BMI is 23 and higher. I'm sure Prabir and Larry have other thoughts with the panel on the questions.
Yeah, but I can start off with yours. I think it's a really good point. I mean, there's a huge difference in the amount of body fat, for example, between South Asians and other races. And I will also say that, and maybe this is a little bit of my own personal bias, but the old Barker hypothesis about if you are born under conditions of relative malnutrition, you end up having a thrifty phenotype, and even if you don't go completely obese, that may not be a good thing. I do want to comment on the Ayush question, which I think is a really important question. So in the Ayushman Bharath plan, you can have Ayush professionals at your primary healthcare level, and I think it's mainly Ayurvedic professionals rather than everybody, rather than all of the Ayush specialties. I do think that it is important because very similar to the Atta concept and people from the village, the people who are Ayush physicians may actually have a much closer connection to the rural areas or the smaller towns that they are in. And that's always been a problem in India about getting MBBS physicians to get into areas that are outside the big cities. So again, I think that would definitely be part of the larger vision. And I think that there is potential in that. I think
I'll just like to comment a bit on also why people can have their metabolic profile. So there's the Parikh hypothesis, which is of course that at birth you already are somewhat programmed. But when it comes to blood pressure rises and steadily with age. Okay? And there's reasonable evidence, maybe not perfect or airtight, but that it's caused by high sodium intake and low potassium intake. India has one of the lowest potassium intakes in the world. It's the countries in that region, Bangladesh, India, Sri Lanka, if you sort of line them up, all of the low potassium countries, like 9 out of 10 of them are in India. And sodium intake is extremely high. So obesity is layered on top of a bad diet. The other aspect of diet that I think hasn't been mentioned, and I don't know much about it, is ghee, which I understand is very common, food that people eat. They might be vegetarian, but they use this in their cooking. And so a lot of chronic disease starts really early in life by dietary habits that have been, part of the culture for a period of time. Probably made worse by current changes, westernization.
I'll just take the one that was not answered. About the comorbidities. This is, I think the solution is definitely what we hope is getting more care focused around the individual and not look at it disease by disease. But we are still a long way away from that. And hopefully we get that. For example, in US, what Prabir mentioned about the CKD, there's a lot more coming together of chronic kidney disease, cardiovascular disease, and metabolic diseases coming together. It's something that is still in process, but I hope that with the PCIC model of care, there's a better chance to addressing some of these cross technologies.
So thank you, panelists, for responding. We're almost at time, but I'd like to add a question for Tara while Chirag is looking at the polls. Mental health and mind health is a little bit different than what we consider normally NCDs. So I think, we're talking about cardiovascular and diabetes, etc. So from your perspective, Tara, where do you see as points of intervention? Because you've got an enormous amount of data. And what does this now mean for young people and, parents, teachers, schools? Everybody's worried about these things. So what do we do?
I think we need to have a lot of structural interventions. I think a lot of the things that, cause these challenges are lifestyle related. And I think schools is one of the places where we feel that you can actually make a big difference to the way kids are, what food they're served, having exercise in schools, how you foster a sense of belonging, community, friendships, the tech policies. So I think one of the big aspects is how do you create an environment that's conducive to strong mind health, essentially, so that you don't have so many kids falling off. And I think, the other aspect that, so many, you talk about all of these other diseases, metabolic and other diet and lifestyle, all of these, the brain is not immune. All of the same things have impacts on the brain. And so I think, the lifestyle aspects, a lot of the same things that will be preventative of other diseases will be preventative of mental health challenges as well.
Thank you. So you guys have been great audience. And so thinking about Mahatma Gandhi and the Swadeshi movement, this is one of the take-home acronyms that you can remember. If everybody thinks about 2 things that they would change around them or with their family members, I think we can give a good pushback to these non-communicable diseases. So in terms of polls, when I put this in the polls, we got 26 answers. And the top one is diabetes and diet, and the second one is awareness of numbers. People should know their numbers, they can do something about it. But all of them they received over 10 points. So I think we understand the web of these factors. Thank you very much.
It's like a big child. I'm sorry. That's what.
Yeah. Let's go deep straight.
Oh, my media project, so that was Chirag. This one too, right? Yes. I thought you said. Yeah, I always say like last year, but it's not last year. Oh, it's huge.
So another child was gone today. Yeah.
It doesn't make sense. And then I worked how action on It's about 120. It's about-
Thank you, Dr. Chirag. When I suggested you attend my panel, I didn't actually attend your panel all the way. Thank you very much. All right, distinguished panelists, please have a seat. Thank you so much. So the mic there. We'll head that around. Let's have a seat. So thank you all so much. I guess we'll have a seat then. So we're starting a bit late. If it's okay with you all, we're probably going to go to 2:45. Okay. And then the break is supposed to be from 3 o'clock, but yes, it's really not short. 3:30. Okay. Well, thank you all for attending. This is a very important session. We look forward to a productive discussion over the next 30-40 minutes. The main task of this session is to explore issues pertaining to implementation of healthcare innovation in India. You know, there are hundreds of innovation projects that we hear about that are proposed, that are piloted, that are suggested, you know, all sorts of really cool things. I think they call it pilotitis. It's like a lot of pilots going on of cool ideas. But what does it take to move those to real impact, to implement them? This is the subject of today's panel. Is it a matter